Okay. Should I start, Basha? Okay. Okay. My name is Steve Gloyd. I think I know a lot of you. I direct the MPH program and have for a few years. And I'd like to welcome you all to our Spring Alumni Conversations, which is a special event that's put on by our communications team and our alumni group, and organized, spearheaded, and everything else by Basha Otto. And so I want to give a huge shout out and thanks to Basha for making this all happen. You do great work, Basha. It's wonderful. And this is a great opportunity for all of you who are either new or have been around for a while or just want to listen to some of the alumni from our MPH program. And today we have a remarkable group of alumni, incredibly special people who have been both good buddies and successful alumni, starting from 2010 until just recently, a couple of years ago. And the way that we're going to work today's session is that I will briefly introduce all three who will be talking with us. They will, in about 5 minutes, kind of present what they've done since they graduated from the program, maybe a little bit about how they got into the program, what they've done in the program, after the program, and then after all three have finished, which will be 15 or 20 minutes, we can kind of open it up for Q&A, and we hope that you all participate in the Q&A. So that's what we have in mind. We're going until 1 o'clock. Basha, anything else I should say before we start the quick intro?
Nope, you've said it all. Thank you, Steve.
Okay, so the three alumni that we have are Dr. Beatrice Tomay, Eli Kern, and Hannah Atlas. Beatrice is a medical doctor with a master's degree in public health from us, obviously. She's also got a PhD in infectious disease, and she can tell us a little bit about that. And has worked on HIV in kids, both in Brazil, where she's from, as well as in Geneva. And a little special piece that I hope she talks about is that she, before she got before she started her her MPH here, she worked for HAI, Health Alliance International. So we actually kind of recruited her to come here. So it was really exciting. So that first will be Beatrice. Second will be Eli Kern, who is now an epidemiologist with Public Health Seattle King County. He's also a clinical instructor in the Department of Health Services. And he's an epidemiologist for Public Health Seattle King County and does a lot of evaluation work, assessment work, and he'll talk about that. And then Hannah Atlas completed her MPH just actually last year. And also got a certificate in WACh, the Global Health of Women, Adolescents, and Children. And after graduation, she began working as research coordinator for the Gut and Child Health Survival Priority Area within WACh Phil. So her certificate was, an opening to her job. So the way we'd like to do this is each person should go about 5 minutes or so to describe kind of, how you got here, where you've been, a little bit about what you liked or gained when you were here, maybe what you didn't like too, in terms of your courses, your general activities here beyond courses and classwork, recommendations, for people here. And then also a little bit about how you got your first job, what you did when you left this place, when you were kind of worried about, well, gee, what am I going to do now? So hopefully you can kind of give a little bit of a trajectory of where you've been. So let's start with Beatrice. Welcome.
Thank you, Steve. Thank you so much for the warm welcome. Thank you, Basha, for the invitation. And I'm really, really excited to be here with everyone today. So Stephen already kind of introduced how I got into the program. So I'm a physician. I was trained in Brazil. I got extra training in pediatrics. I finished my residency and I moved to Mozambique because I wanted to work in an African country. And when I say that, it was really without very a lot of knowledge on how different these countries could be and how systems could be in Africa. So I had this dream that I would when I finished my training I would just go and work, and I did, and I was working at the Ministry of Health at the pediatric hospital, and we at this point we were just starting to have pediatric formulation for antiretroviral treatment, so it was a very exciting time. And Steve did a lot of work there, had done way earlier, but continued to work a lot in Mozambique. And I had, I guess, maybe worked there for 2 years or something, and I really felt I needed more training because I was just out of, my clinical training, and I felt prepared to do what I was doing. But soon enough, I realized that we were doing more things than just being a clinician. Actually, we had to plan for a program to be scaled up to the rest of the country. In this case, pediatric HIV care. So I felt I was doing a lot, and I didn't have enough training to be doing this move from being a clinician only to being a clinician that also did public health. So I started to talk to friends, and then one day, maybe Steve, you remember this, a friend that also worked in Mozambique said, Stephen Gloyd runs this amazing program in Seattle. You should maybe talk to him. And then I went, and I really, this was a super important point in time for me. And we sat down, and he said, the first thing I want you to tell me is, where do you see yourself in 10 years time? And no one had ever asked me that question. It's so direct. We had just met, and I had no idea. I had no idea, but I closed my eyes, and I remember having responded, I have no idea. I really don't know where I'll be, who I'm going to be, with. But I really do know I will be working in public health. That's for sure. And this is why I really feel I need more training. This is why I want to get into your program. And this was it. I think that convinced Steve, and he really helped me, navigate the process that for me doing from Mozambique, the application and everything was very hard. And then I made it to Seattle. This was 2008, and then I went back. So this is when I started working with HII, which was this again this amazing organization that did so much work with Mozambique, directly with the Ministry of Health. I had so admiration for them, and I went back to Mozambique for my thesis research, and working with pregnant women living with HIV. And I did qualitative work, which for me was different. So it was a different skill that I felt I gained there, and I continued to do qualitative research after that. So I guess Seattle was very, very, very important, time for me to learn these, and among so many other skills that I use every day now, really. So then after Seattle, I had being Brazilian, I had a particular situation in my visa that I could continue to work in public health for a year. This is a particular situation, after you studied 2 years in the US, for us, we could apply to do that. So that really opened a door for me to apply for jobs within public health. And I started working with another organization based at Columbia, continued to work in HIV programs, in particular pediatric, pediatric just go back and forth very frequently. I perhaps should say as well that while I was in Seattle, I took some French, which was very important to me, because then, starting from there, I was able to work in Francophone countries, which was to me was very important. was a great addition. So I worked a lot in the DRC, in Cote d'Ivoire, and Burkina. So, and I continue to do that. So coursework that I felt was really, really important. And then after, so I spent another couple of years in New York doing that, always working with African countries. And then for personal reasons, I was already away from home for almost 10 years, a little bit more perhaps. So I got back home. And then it was, which is Brazil. And then it was a little tricky to fit in again after having been, away for such a long time. But regardless, quickly enough, I managed to get inserted in the public health system in Brazil. And because I always enjoyed research so much, I got into a vaccine development work, which was different, but it was still research and working with the public health system. And that was very, very interesting. And then again, I guess some of the skills that you get during your MPH, such as program management, M&E, you come across these needs all the time when you get a job like that. And then after that, so this was a couple of years, and I started to work at the university that I trained as well as a teacher. I was part of the preventive medicine department in São Paulo, where I grew up and studied teaching epidemiology. So this is when I really, doing the global health track, you had a couple of mandatory epi classes, which were amazing. But this is when I really hoped I had taken some extra courses, because when you're teaching is is when you really feel how you really need to, how epi is such a huge endeavor, and the UW is such a great place to study epi in particular, same as biostats. So I really felt that when I started teaching myself. And then just recently, I took up a job at the Global Fund. If perhaps you're not very much familiar, but it's an organization that's it's a funder, really. It's that funds a lot of HIV, TB, and malaria work in developing countries, mostly, so mostly African and Asian regions. So this is where I am right now. I live in actually I don't live in Geneva, but I live in France at the neighbor just nearby. And I'm an M&E specialist for the Global Fund. And then again, on top of the language skills, on top of the program management skills, of course, being working with M&E every day, of course, everything that I learned in epi, biostats, it all comes back really, really strongly. So this is me in a nutshell. Steve, I don't know if I've covered most of what you'd like us to, but we can talk more in the Q&A.
Yeah, I think that's great. Thanks, Beatrice. And we'll definitely get back. I got a couple of questions, but I'll wait until we hear from Eli and Hannah. So Eli.
Hi there. Thanks, Steve. So let's see my trajectory. So I started out after college actually doing work in cell biology, studying cholera. And so I was always interested in health, but my initial plan was to become a cell biologist and sort of study infectious disease from that perspective. And it was really interesting to me, but I started to get a little disillusioned after a couple of years when I realized that sort of the research that we were doing wasn't really what was needed to make a difference in who was dying from cholera in low-income countries. It was really had more to do with public health approaches like clean water, toilets, so on and so forth. And so after a couple of years, looked for volunteer opportunities abroad and ended up going to Tanzania, where I taught biology in a high school, which included in Tanzania at that time, sort of HIV transmission and sexual reproductive health was part of the biology curriculum. But there was a lot of discomfort in schools around teaching that for a variety of reasons. And so really got into HIV prevention work through that vein, and also had an opportunity to work at a sort of youth-focused prevention organization there that did things like condom demonstrations in bus stations or outreach to commercial sex workers, and started to learn about public health, essentially, which I hadn't really had much exposure to before. So after leaving Tanzania, wanted to get more training, not in the original field that I had been interested in, cell biology, but wanted to get training either in sort of a direct service profession like nursing or in public health. And so I ended up doing both in sort of a staggered way. And I went to University of Rochester in New York to get a bachelor's in nursing, and then moved out to Seattle and started working at Harborview as a nurse there at night. And about a year into my job there, also started the MPH in Epi program at UW with a global health focus. And so that was sort of the link to DGH. And it was a wonderful experience, sort of working as a nurse and then taking these public health courses at the same time. I learned so much about inequality in Tanzania that I had never been exposed to growing up in New England. But at the same time, I saw a different side of inequality at Harborview because there were issues that I dealt with every night there that I hadn't come across in Tanzania, such as heroin use or refugees coming to Seattle and living on the streets and different things like that that are not unique to the United States, but certainly were issues in Seattle at that time and still are. So I started to develop a deeper understanding of the social determinants of health, both from my work as a nurse, in that direct service approach, and then also in my coursework at the University of Washington. I loved my classes, both I had because I was an Epi MPH, most of my classes were epidemiology, but I had some global health courses, which were really wonderful as well. About midway through my program, I quit my job as a nurse. It was hard for me to work full-time as a nurse at nights and also go to school in the day. And we had our first child at that time, my wife and I, so it was too much for me to juggle all of those things. So stopped working as a nurse and found a research assistantship actually in the newly formed START program. I don't know if folks know the START program, which is Strategic Research and Analysis Training Program. That at that time had just gotten started, and I was in the first cohort. And essentially at that time, and I think it still is to some degree, it's sort of like a faculty and student consulting program for the Gates Foundation. I think they have more clients now, but at that time it was just the Gates Foundation. And it was a fascinating opportunity to understand how the Gates Foundation and the teams within there, the content specific teams like malaria or tuberculosis, whatever it may be, how they use consultants and strategic input to form region level or country level or program level strategy. And I learned a lot through that program, including had some opportunities to use some of my newly developing statistical analysis skills through my Epi coursework. And but one of the things that was challenging for me about that work is, I think particularly as a white male, I was struggling with the feeling of doing global health work from afar, because the legacy of colonialism and neocolonialism was still evident in everything in global health. And so the feeling that I loved in Tanzania when I lived there and worked with and for the community in which I lived was absent for me as a white male trying to do this work from Seattle. And so I was struggling with what I would do after graduation. And so one summer, the summer before I graduated, I had an opportunity to do a domestic public health internship at Public Health Seattle County. There was a opportunity called the Epi Scholars Program, and I applied and was accepted for a summer internship in their STD clinic. And it was a data analysis and monitoring project. And I fell in love with it. And I realized in retrospect that one of the things I loved was that I sort of found that feeling again of working for the community in which I live, and that it felt better to me. And so when I graduated, I still wasn't 100% sure which direction I would go, but luckily there was a job opening at the Public Health Seattle County in the program that I still am working for, which is called Assessment, Policy Development, and Evaluation. And it's sort of a cross-cutting data shop. We do monitoring and evaluation for internal projects as well as external partners. And what I loved about it, and what I still love about it, is there's a huge focus on equity and social determinants of health, and particularly working with community partners in community-driven evaluations of things like, well, now there's a lot of work we're doing related to COVID. So vaccine-related work, isolation and quarantine-related work. But pre-COVID, things related to use of community health workers to treat asthma in the home, partnerships across sectors. That's one of sort of what I've worked on mostly, is trying to form partnerships across things like the housing sector, the criminal justice sector, the public health sector, and healthcare delivery sector, for which my nursing background has been really helpful. And part of that cross-sector work is convincing people and organizations that we should be sharing data so that when we go out and evaluate a program that is supposed to touch both housing outcomes and healthcare outcomes and criminal justice outcomes, that we're not all doing our own evaluations, but we're linking our data and asking questions from a more holistic point of view, which is essential, I think, for equity-focused work. So that's where I still am. And I'm happy to be still working in domestic public health, even though I loved my global health training. In terms of classwork and coursework that I found helpful, I think methods and statistical skills, I mean, for me as an epidemiologist, are really useful. But in particular, I think it's useful to think about where the trend is going. So I was trained in Stata when I was at UW, but now I use R, which is what our unit has adopted. But in particular, if you look at sort of open source languages like R or Python, I think that's more sort of where the future is going. That's for statistical analysis. Data visualization is another whole skill set. So we use Tableau right now, but the tool is unimportant. It's really understanding how to take complex technical information and create a variety of data products that can reach different audiences. That's a skill, a very marketable skill that would be useful, not just in public health, but almost in any profession. Design, so having an eye for design. So understanding how to plan a data product or a presentation, thinking about your audience. And then similar to that is presentation skills. So that's one of the things that I am most grateful to that START program research assistantship for, because I had all these opportunities to sharpen my presentation skills in front of these Gates committees or project teams, which was really nerve-wracking to get up there as a student and try to present, these half-baked ideas. But what it did is really sharpen my presentation skills, because at least at that time, the culture was, it wasn't really the academic setting where you sort of leisurely go through, here's my research question and my methods and my results, and then here's my conclusion. And you make the audience wait for the end. No. At Gates Foundation, you start with the conclusion, at least at that time, and then you can fill in, going backwards, because people are busy. So that was excellent training. And again, presentation skills, the ability to take complex ideas, synthesize them clearly and present them written or orally, will help you in any job. It doesn't really matter where you go. And then I guess the last thing is, depending on where you'd like to be, if you want to be in academia or you want to be in practice or you want to be in both or some other field, that really, I think it would inform for me what it might be good to get experience in. So for me, because I wanted to go into public health practice, it was crucial that I find a practice-oriented internship, because I was worried that when I graduated, even though I had this degree, I wouldn't really be able to market myself or differentiate myself from other applicants if I didn't have some practical experience. And the final piece there is, as a population health practitioner, I find my direct service experience as a nurse essential, because you sort of don't have that context of the lived experience of people, why they seek healthcare, why they don't seek healthcare, why people end up in the hospital, which often has nothing to do with healthcare. That is really, for me, an essential daily sort of context of how I approach my evaluations, my monitoring work, my public health projects. All right, I think I covered what I could think of, but I'm happy to address more later.
That's great, Eli. Thanks very much. You raised a lot of questions, and I've got a few here that I want to ask you. But let's go on to Hannah and hear from Hannah and your trajectory and where you are, where you've been, and where you're going.
Totally. Yeah, thanks, Steve and Basha. And it's really an honor to share this panel with you both and hear about your experience. I definitely feel a little bit more junior, so hopefully what I have to say will be relevant. Yeah, so as Steve said, I'm a little bit more proximate to being in the MPH program. I graduated just last June, and since then started working at WACh as a research coordinator in the gut health and child survival priority area. And our research portfolio is sort of a mix of enteric disease, child growth, nutrition, and NTDs. So really like a very diverse array of grants that I've had the pleasure of working on, and just different topical areas and methods and personalities, I guess, I've been exposed to. But yeah, so I grew up in central Seattle, which I know is a little bit rare these days. And after graduating from undergrad, I knew I wanted to go into global health research, but wasn't really sure how to get my foot in the door because, in the grand scheme of things, I really felt like, having like a BA from a liberal arts college in like a sort of public health science wasn't going to get me super far. But it was sort of, an iterative process of just making connections and eventually getting a staff role at DGH. But, I think the part that doesn't always get acknowledged in some of these conversations is, the reality of living in Seattle during, this heavy time of gentrification is just having to earn a livable wage. So in this period, I also taught yoga and like worked at a plant store and just like really was trying to just, make a living and support myself. But yeah, so in my staff role in DGH, during that stretch, between undergrad and starting the MPH, I moved to Western Kenya, where I worked on a few of our ongoing projects there. And that was really valuable field experience that I think was super crucial and really instrumental in just shaping my perspective and kind of clarifying a little bit about what the aspects of research I was interested in and, what made me feel uncomfortable and why. So that was a huge learning opportunity and growing opportunity for me. And then during my MPH, I worked as an RA for WACh for the same group I now am employed by, and as a TA, and just was trying to keep my funding afloat. And did my practicum in Nepal, but really just looking back, I think, my cohort, I'm sure everyone says this, is just amazing. And we all were really close, and it's just such a great group of people that, I wouldn't have normally been in the same room with and learning with. And I'm just so grateful for them. And hi, Stephen. But yeah, I really developed a strong connection with some women of color in my cohort, and we sort of formed this like professional personal support group, and I talk with them and lean on them just about every day. So that's been really important. In terms of like classwork, I think, as Eli said, having a really strong and pretty clearly defined methods background and skill set was really, really helpful. I think as part of the WACh certificate, I had the opportunity to take, a lot of different types of topical seminars and just like really get a sense of what's going on in all of these different fields. And yeah, I think one class that I would really highly recommend to anyone who still might have space in their academic calendar would be Professor Edwin Lindo's Critical Race Theory in Medicine. I'm hoping that he still teaches that class, but that was like, for me, this really, really important learning and listening space of just kind of grounding the history of medicine and global health and colonialism in critical race theory. I can't emphasize and endorse that class as much, like enough. Yeah, and I guess, I don't know, this is like maybe a little bit more meta, but I guess just outside of, classwork and exams and all of those things, just also, the MPH and, with mentorship and guidance from Steve and Deepa and Awa and just all of the MPH program advisors, just like really thinking about, our field and the history of our field and, my power, position, and privilege as, an Asian woman of color who was born in a different country, but educated and raised in the US, just really spending some time like in self-inquiry, I think is really important, especially before, venturing into the job market. I don't think that's something that's necessarily laid out as like a necessary step after graduation, but for me has been a huge source of clarity and figuring out, what it is I really want to do. So yeah, what else was I supposed to say?
No.
I tried to make a list, but totally got off track.
No, I think what you said is great. And so I think we can open up for questions, but I'm going to start out with the first one at least and follow up just on what you said, Hannah. which is that you were very special in your cohort in the organizing and work that you did for the Women of Color group. And that was a very big deal. And you spent a lot of time on it, as I remember, and it made a huge difference for people in your cohort. My question to you is, how do you see that as playing out now in your career? Both in terms of the support that you still have that you already mentioned, but in terms of sort of, you know, if you're thinking of, and I think all three of, you know, of you guys are very much directed towards social justice and making a real difference in global health. So how did that experience of mobilizing women of color in your group, how has that played out in your work life, even though it's, you know, hasn't been a long time?
Totally. Yeah, that's a great question. I think, you know, the formulation of this group was a very natural process. I think, you know, being women of color in like a predominantly white institution, you know, we sort of naturally gravitated towards one another. And then it became, like you sort of alluded to, Steve, like this more formalized group. And, you know, we applied for different seed grants and got funding to do like workshops and retreats. But how it's kind of playing out now post-grad is, you know, we all, after graduation and, you know, just with COVID, we've all scattered to various parts of the country and are sort of all in our little pockets of work and continuing education. But I mean, you know, for me, the way it looks like on a weekly basis is I just have a group of people where I can go to if I'm, you know, trying to work out a situation at work or need support, or even want someone to read like a part of a manuscript that I'm writing. It's sort of this like really open and just really supportive network, which is of course virtual now. But yeah, I mean, I think having people in your corner who have your back, who are a little bit outside of like your immediate like work sphere and team sphere, just to kind of have like a fresh perspective, that's been so valuable. And just having people who know you and can, you know, hold you accountable and call you out when you're like bullshitting yourself, I think has been really important. So I hope I'm allowed to say that.
Really, I thank you a lot. You know, as I think those of you who are in the program now and all of you, you know that the program at least tries or has tried to sort of put global health into the context of social justice and making a real difference, you know, in not just your careers in global health, but also looking at global health as a way of sort of changing the world, changing the narrative, and really moving towards a justice approach. How do you keep that up in your work? Or do you? I mean, is that a big piece of your work, and how do you keep it up? And so I think let's start with Beatrice and then Eli, and then if you have more to add to that, Anna.
Thanks, Steve, for that question. And I think the first thing I would like to say is that, you know, bringing social justice to the global health discourse is not exactly the rule. So just to say that after having been at the global health department in particular, you get in, you know, you get embedded in this. And of course, I'm Brazilian. You know, I've had always studied, you know, like public schooling and worked in the public health sector. So I knew in practice what that meant. But having, you know, having this incredible group of people in the northern hemisphere talking about that, that is not the norm. And I have been, you know, to other public health schools and taken other courses, or have been part of different working groups. That again, this is very special about this group of people. So, you know, we should really be proud and really feel privileged for having shared that. And I wasn't ready for that. I was like, oh my God, these people are really talking about what we live, what we see. And so this was to me very important. I felt at home very instantly. And I think, again, to me, this is absolutely, Steve, as to your question, it is part of my everyday, for sure. I think there's no way you can practice public health and global health without having social justice, you know, in everything that you do. This is what I try. I mean, and it's being a clinician, but then now being more, from the public health perspective. And I guess that now thinking about it, I'm also involved in a lot of bioethics work, and I'm currently part of a working group that's discussing ethics and COVID-19 at the WHO. And I think this is, I think I'm biased, and I'm all the time I'm repeating myself and trying to bring this to the table, and this is something that always gets me very inflamed. So again, I guess with this group of people, I felt welcomed, and I felt strength, and I felt empowered. Like people like me could go back home and then speak of social justice, because we have learned that the northern hemisphere can do that as well, and so well. So to me, this it could have been okay, as I mentioned before, that there's the hard skills that you learn, and epi and biostats, and these are key, but there's this feeling of empowerment that you get, that will change your career and your day-to-day life forever. So I feel very strongly about this, Steve. Thanks for bringing this up.
Great, thank
Over.
you. Eli.
Thanks, Steve. Yeah, I mean, I'm biased too, in that I feel like if it's not about equity and social justice, I sort of would ask, what's the point? And I think that that's part of what keeps me at Public Health Yalkin County is that there is a clear commitment to equity in all decision making. At the same time, there are incredible problems in our country and locally, right, with things like racism, including structural racism. And I think these past couple of years have only exacerbated that. So King County, as a local government entity, last year, declared racism as a public health crisis, although it's a crisis in every sector. But what that means in terms of a local government is that there's now policy priorities and funding behind that, and that trickles down to programs like ours as well. I think that I believe that the ability of any organization to do equity and social justice related work relies primarily on who makes up that organization. And so as a manager now, which I wasn't obviously when I joined, but I've been a manager for a few years, one of the most important things I think I do is hiring and retaining of staff. And so there are populations who are underrepresented in local government work, including evaluation work, right? And so we have clear priorities working within the laws and within the local government agency policies to address that, to basically bring in experience and talent that represents what we don't have. And I think that's the most essential thing that I can do, both as a manager, but also as a white male, which is that use the privilege that I have as a white male to essentially lift up the voices of those around me. Because no matter what I do, no matter how well informed I become as a white male, I'll never be able to represent any other perspective than a white male. And so I think for me, that's what's most important to me of how I approach it. Beyond that, it's the working across sectors. So it's that holistic view, right? So I think that every time we partner with yet another sector, whether it's a housing authority, whether it's a jail, I think that we have a better opportunity as a local government to look at health and well-being from a holistic point of view. So that when you begin to look at things like, oh, I see, maybe the reason why these people are showing up in the emergency department is because they are homeless. Or why are they homeless? Oh, they have behavioral health concerns. Oh, they're being jailed, and then they start to withdraw from alcohol. There's so much complexity, right, in our local community alone. And so I think when you widen the horizon of evaluation questions to include more and more sectors, you inevitably strengthen your ability to think about equity and social justice.
Excellent, thanks. Hannah, do you have anything else you'd like to add? I mean, you started the discussion, but we're coming back around to you because you actually were pushing this when you were an MPH student.
Yeah, no, I appreciate what both Eli and Beatrice have shared. I mean, I think the only thing I'll add is, in my last year, I think transitioning from a student to staff comes with, elevated power and position in the department, and just having the opportunity to be involved with the strategic planning process and the work and the priorities of the DEI committee, and then within my research group itself, shaping our research practices, like everything from how we approach publications to how we facilitate calls is, been a really great opportunity just for me to be in those spaces and add to those conversations. Like, I think, I will admit it's really exhausting and, sometimes falls on deaf ears, but so I think it's also important that, people of color do protect their energy and prioritize well-being. I guess the other thing I'll say, and I try to keep in mind, is like, yes, bringing a social justice lens to, my career has been like central and has guided so many of my decisions. But, I'm also able to like feed that other part of my soul and my identity outside of my career and being really involved with my community and community organizing, and just trying to keep in mind that those things can be like both a little bit separate, but also intertwined in the same way, if that makes sense. And just, there's a lot of space outside of our jobs and our institutions and our job titles that, allow us to think and apply social justice lenses. And yeah, just wanted to add that. But of course,
Great, thank you. That's really nice to hear that sort of the three lenses of justice that you guys bring in. Okay, I've been dominating the questions so far. Basia, do we have other questions that have come in?
No one has submitted any questions yet. So if you want to ask a question, feel free to just, raise your hand or write it in the chat right now. I don't know, Steve, if you want to just continue asking your next question.
I know Mohammed would
there's
raise his
Mohammed.
hand.
All
Yes.
right.
Good.
So,
Yeah, hello everyone. Thank you for sharing your perspectives. Just a quick question about how do you see the balance between quantitative and qualitative skills that you have developed and built through your journey in the program?
Can I start since I brought this up? I think thanks, Mohammed, for the interest. So when I joined the program, I had no skills in qualitative research. I've enjoyed reading, and but all the research that I had been, exposed to and conducted was quantitative. As a medical doctor, I guess this is what you get pushed to most frequently. So I took it up as a challenge, like an extra, like an added challenge to be in the program. Like I was going to do something that was, to me, was, I had never studied the methods, and I got very, not surprised, but maybe surprised in the beginning how there's, there are strict methods to it, and how you conduct research and how do you report your research. So again, this was a deep dive for me in a completely different research, area, and it was, and this was I did both my practicum during qualitative research. I actually just recently published it because I revisited the data and I've added a few updated things, and I've recently published my practicum work 10 years later. And my thesis as well was qualitative research, and this was to me it was a trip. Again, it was a real opportunity to really get exposed to something completely different. And I think your MPH is a good opportunity to do that. Over.
Hannah and Eli, you want to respond to Mohammed's question?
Hannah, you want to go first?
Go ahead, then I can add it.
Okay. Well, it's one of the things I love about the program I work is actually that we have two groups of technical staff. We have epidemiologists and we have social research scientists. And the epis are the quantitative folks and the social research scientists are the qualitative folks. And there's, of course, people who have skills in both, but generally a person has skills that are stronger in one than the other. And so what I have found is that one of my greatest joys of working there is being on part of teams that includes quantitative and qualitative folks. And generally the way that we approach evaluations is that there's always quantitative data. We usually use existing data because we don't do much primary data collection on the quantitative side. And the quantitative data is useful from even just a descriptive analysis perspective to understand differences, including health disparities, including things like change over time in a given outcome. But the qualitative approach, which is really where we build out a lot of our community partnerships, is essential for answering the question of why. So we might understand that people who are lower income are more likely not to get a primary care visit, but why? And you can ask why questions on a survey and quantify it, but it's typically quite hard, especially if you want to collect information from different language groups, right, and different ethnicities within King County. So usually our approach, and this has become more true over time, is to have teams of people with both skills. And our evaluations in that context tend to be heavier on the qualitative side. But that's specific, I think, to our program, and is very true, I think, within many sort of local public health agencies when we talk about evaluation. But that also has something to do with limited availability of quantitative data, limited funds for primary data collection, and also what the community and our community partners are asking for. So I would just, I guess, to summarize, both have remained incredibly important for me, even though I myself haven't really developed skills in qualitative methods. I've learned how to work better with people who do.
Great. Hannah, anything to add to that?
Yeah, I mean, not a lot. I think I'm a little bit more junior in this group, but I think during my MPH, I very much leaned towards quant skills and didn't unfortunately take a qualitative methods class. And now, in our group, when we're doing something like, writing an R01, like an NIH grant for a clinical trial or something, we'll usually always integrate like an AIM that's, qualitative or mixed methods or implementation science focus. And I really do think there's a big gap in people who can sort of speak both like an epi quantitative, but also implementation science kind of language, and having those two integrate with one another in like a very logical way is a challenge for sure. And I mean, I think the other thing is, taking a CBPR class and having exposure to that method is something I really think is important, and hopefully a direction that our field is going to move towards more of. So, yeah.
Great. Let me just highlight something that Beatrice said at the beginning, is that she talked about publishing the work that she did 11 years ago or more as part of her practicum. And I think that's such a wonderful example, because it underscores two things. One is that oftentimes we undervalue the work that we do when we're junior. We sort of think that, oh, well, gee, who's going to be interested in this kind of stuff, or I'm not ready to publish it. So publish it now. And the second thing is, even if it's sitting around for 10 years, it oftentimes still has value, and therefore still publish it now, even if it's 10 years later. So I think that's just totally cool. Gretchen, you've got your hand up.
Did you say me?
Yes.
Oh, okay, my fault. Hey, so thanks everyone, panelists. This has been really insightful to hear all of your perspectives on this. And I think this question is maybe a little bit more targeted towards Eli, but if anybody else has any insight, I'd love to hear it. So my question is, Eli, what you said really resonated kind of about having that global health background, but looking to sort of translate that into locally relevant experience in terms of like what you're doing for your career. And I was wondering if maybe you could just talk a little bit more about, how you connected the dots with those two when you were doing something like applying for jobs. And you said you do hiring as well. So maybe if you've seen anybody else do that effectively as well. Thanks.
Yeah, sure. Yeah, no, I've certainly seen it a lot more now being part of the hiring process. People switch back and forth all the time. And I didn't know that when I was in school. I thought that I had to choose one and then sort of be with that forever. But and actually that summer that I chose that Epi Scholars internship, I also applied to a PATH internship. And I was really ambivalent about which I should prioritize. And I remember when I turned down the PATH internship, I sort of shared a little bit with the recruiter about why I was doing that. And he actually shared with me that he had started out in domestic health. He was like the Washington State STD epidemiologist and then moved over to global health. So there's a lot of relevance across the two. I mean, after all, they're both public health fields, right? And so, but there are unique things to both. And I think in particular, something that, at least at the time, that was challenging for me working at the Gates Foundation was it wasn't as common to have conversations about inequality in the way that we talk about it in domestic public health. There's a huge focus on racism and structural racism right now in most urban public health departments. So there's like, and that's just one, I'm not to overemphasize that, but that's one example of that. There's priorities are a little different. They can be different, and also the terminology that you might use to describe your work. But in terms of being able to apply and market yourself, I think that when you're working on your resume or a cover letter, and you know that you're trying to apply for a domestic job, but your experience might be global health or vice versa, focus more on the skills, right? Both hard skills and soft skills. So what software you might use, or your presentation skills, your organization skills, your ability to build rapport quickly, right? Work across organizations, and not as much the topic. Because I think that sometimes turns people off if they look at, and I've been part of hiring panels where someone's like, we don't need someone who's an expert in tuberculosis. I was like, the tuberculosis is sort of irrelevant here. Let's think about what work they have done. Do they have the skills? Have they been in positions that we're hoping them to sort of mimic here? But in terms of our unit, yeah, we've hired many people from IHME who have come over from the global health side. And we've also hired evaluators who've come from the UW who have done global health experience. And so it's really not about the field. I think it's about the individual in terms of what their interests are and what skills and background they bring.
Excellent. Thank you. Other comments to that question or other questions?
Yes, Steve, maybe I'll just come in I think Eli just made a perfect point, but just to reemphasize, I go back and forth all the time. I was just in Brazil doing very local public health job, and now switched again to global. So it's actually an advantage that you have, I think, because going the local will give you the field experience. When later, like now, I talk about countries' health systems for information. Like a year ago, I was entering data on these forms. I knew what worked and what didn't work. I was an end user, and now I can discuss this more properly and try to fill in the gaps that I know so well, because years before, and probably years later, I'll be back there and on the computer entering data. So I think it only brings advantages, and yeah.
Great. I have a question that sort of spins off of that one, which is that all of you guys are fabulous examples of doing local work and global work. Even with the short time that Hannah, you've been involved, post-graduation, it sort of seems like, you look at global health in a very global way, but definitely including that local piece. And most of our graduates are that way. So one of the things to think about when you're doing your degrees is to make sure that you're thinking about both. One piece that I think ties in what we talked about earlier about global justice and health justice is that oftentimes in the local environment, you may learn things in your global health sort of arena about some of the broad issues, whether it's, inequality, oppression, racism, whatever, that have where your standing or your ability to do things oftentimes is stronger at a local level than at a global level. So what I'd like to ask all of you is, to what extent do you deal with some of these issues around justice, inequality, oppression, in your environments, in a very practical way? In other words, to what extent do you do your public health on the streets or in op-eds, sort of beyond the office? I think of Beatrice, you just left Brazil, but you were in Brazil at a time where, the public health issues in Brazil are on the streets, we've got, you have political issues that have had profound influences on public health. The same is true in Seattle, So where do you, to what extent do you expand your public health beyond the skills in your day job?
Maybe I'll get a stab at this, Steve. That's a hard question, but I think what you just introduced, I think you can't really separate public health from politics. And if you're on the local level, it's going to be your state, your hospital, your city, your state, your president, and if you go global, it's just ads. A lot of politicians making wrong choices most of the time, particularly in my case.
Yeah, you've
So I
got a
think you're
special
never
case.
at rest. No, indeed. So you're never at rest, really. I think I think a big piece of a public health job, regardless of what you do, is communication and really engaging the communities in what you're doing. So I think what we're living with the pandemic, it's one of the biggest moral failures I think we're facing is inequality, right? Inequity in really distributing what the global, what should be global goods. And I think to the core, it's a problem of how you communicate as well. It is and we've lived that in Brazil. Communication has been a big issue. There's been so much misinformation. So I think being very practical, again, I think public health starts from your family, starts from your WhatsApp groups. It starts from every conversation that you have, and again, bringing this, when you live in this, with social justice and equity in your head, this is what you do every time, and every day, and you can't get tired of this. This is going to be what you're going to do for the rest of your life.
You can't get tired with it. Thank you.
Yeah.
We have a couple more minutes. Can we, either Eli or Hannah, do you have something to add to that question?
Hannah, you go.
Yeah, I mean, it's a hard question, Steve. You always come in with the hard questions. Yeah, I mean, I think like Beatrice said, it's not something that can easily like disassociate myself with, or, wear my 9-to-5 hat and then suddenly in like, this other version of Hannah. I think her point of, just really stressing communication and making sure communication, at least, the communication around public health and I guess vaccine hesitancy and distrust of the medical system that I see in my community in Seattle, like it's really being reshaped and influenced by who's doing that communicating, who's, the one showing up and escorting people to, like our elders, to get their vaccine. I think it really has to do with just really thinking about the context that we live in and, what is it that people actually need, not what is it that we learn in a class that they need. It's like, what is it that people need to feel supported and safe and cared for? And I don't think that really answers your question, Steve, but I think that's just all to add at this point.
It's great. I really appreciate that.
Yeah.
Eli, last word.
Sure. Yeah. I mean, I think I agree with everything that's been said. I think I never take my public health hat off. And I think it's, particularly during this pandemic, my neighbors, my mail carrier, the people who have come service things in our home, I introduce to them and they know that I work in public health. And so I get questions daily around like, do you believe in masks? Should we get this vaccine? So on and so forth. And as a parent, I've talked to my kids about it constantly in terms of inequity. And it's so evident in Seattle, you don't even really have to go very far to sort of teach your children about the impacts of inequality. I think one specific thing that I try to do is this connects, I think, to something Hannah just said, is there's a lot of people often blame things on a certain group of people or a certain person. And so, for example, when we talk about vaccine hesitancy, there's often a statement like, what do we have to do to convince people to get the vaccine? And I think it's a matter of perspective. And so the way that I look at that, instead of asking that question, and particularly as working as a nurse, is what does the healthcare delivery system, as one example, what do they have to do to earn the trust of community? It's not on the community to sort of change their minds, right? But it's really about understanding the historical structural racism and oppression that has led to the current day that we see. And so in that context, I always try to approach these personal, whether as a father or as a neighbor or as a client, these conversations around public health from that perspective.
Great. Wow. Well, thank you, Eli. Thank all three of you. Thank you, Hannah and Beatrice. You guys are amazing. You make me really proud of the work that you're doing since your graduation. You're your insights are fabulous, and you've been inspiring, I think, to us all. So thank you so much for contributing. And again, a big thanks to Basha for making this happen. You're a star. And let's keep up the struggle. Got a lot of work to do. So take care, everybody, and thanks for participating.
Thank you, everyone.
Thanks,
Salute
everyone.
continua.
Everyone.
Thanks, Steve. Thanks, Basha.
Thank you.
Pleasure.
Bye-bye.
Bye.
Bye.